Assalamu alaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
How are you?
Alhamdulillah, so far so good.
Let us just let me know you one by one. You can start. Yes, good. Musawa,
Yes, Doctor.
introduce yourself.
Oh, okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Al-Musawa bin Muhammad Hamran. My metric number is 1812615.
You are welcome, Musawa. Okay, the next one. Putri.
Assalamualaikum, Doctor. I'm Putri Sofia. How are you, Doctor?
Alhamdulillah, I'm fine. Thank you.
Alhamdulillah.
Ibn Hisham.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nuridina Nabila.
You are welcome. Only two names? Supposed to be 3 or 4. Okay. Nur Afika. Alhamdulillah. Okay, I may switch off my video because the internet in the hospital are not so good. Okay. Okay, next one is that.
Assalamualaikum. My name is Nuriza Zaira. You can call me Iza, Doctor.
Is Adib.
Assalamualaikum. I'm Adib Irshad bin Baharum. You can call me Adib.
Welcome, Adib. Zakwan.
Bismillah. Assalamualaikum. My name is Muhammad Zakwan bin Rahman. Okay.
Oh, the sea today is very, very unstable. Okay. Another Afika. Afika.
My name is Afika Atira. Just now Nur Afika, right? I'm Afika Atira.
Okay, mashallah. Okay. Atika.
Okay, Assalamualaikum. My name is Siti Nur Atika. You can call me Atika.
Welcome. Nur Afika and who else remaining? It may be our stuff. Okay. So let us start by Al-Kitab. Bismillahirrahmanirrahim. Alhamdulillah. We can start now by the first presentation. Who will be the doctor?
Me, Doctor. Sawa.
Who will be the one?
Musawa, the doctor.
Okay. Suppose in the next time, inshallah, this the one will be blind for the one who is going to be examined. But for the whole team, they must know so they can prepare. Okay. Either the role player, the one who is making a differential diagnosis, the one who is doing the USCI, but it is blind for the, like Musawa today, suppose he doesn't know that all details. You know, he will come as if he is picked for exam. And this will make you more strong, inshallah. Okay?
Inshallah.
Go ahead, Musawa.
Okay, so Bismillahirrahmanirrahim.
Who will be the role player?
It will be between me and Adib. Okay, Bismillah. We'll start first with the role play between medical students or so-called doctors with the patients. Okay, so we'll start now.
Yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. How are you today? My name is Ni'al Musawa bin Muhammad Hamran. I am a year 3 medical student. I was asked by my doctor, Dr. Mossad, to take a history from you. Is it okay with you, sir?
Oh, Waalaikumsalam. Musawa. You can call me Mr. Adi. Today I'm bringing my son, Ashraf. He is a 5-year-old boy.
Okay. So nice to meet you. Nice to meet both of you. Nice to meet you, Mr. Adib, and nice to meet you too, Ashraf. So what seems to be the problem? Can you tell me what is your problem, Ashraf or Mr. Adib?
Ashraf is a bit shy, so maybe I'll be doing the talking. So yeah, he's been having a runny nose for the past 4 days, and 2 days ago he developed a cough, and yesterday he experienced a rapid breathing.
Okay, so I hope you don't mind if during our conversation I'll jot down some notes.
Sure, I don't mind. I don't mind.
So you mentioned that Ashraf have symptoms of runny nose. Is there any other else or any other person, like family members or friends, that have the same symptoms?
Ashraf, do your friends have any symptoms? No. He does not. I mean, yes, you do. Yes, he do have friends. At his kindergarten, having quite the same symptom, coughing and flu-like symptoms.
See, okay. And Ashraf also have symptoms of coughing, right?
Yes.
Can you tell me about his cough? Is it a dry cough or is it a productive cough with sputum?
It is not a dry cough. It is productive cough, and I believe the sputum is whitish, white greenish sputum.
Okay. If you might guess, can you tell me the how much volume of the sputum itself?
It is about half a tablespoon, I believe.
Okay. Does your son have any complaint of chest discomfort or any chest pain or tightness in chest?
Do you? No, he does not have.
Okay. And what about the coughing just now? Does it sound like a barking, a seal barking sounds like?
No, it's just a typical cough.
Okay, I see. Does your son Ashraf has any fever or headache?
No, he does not.
Okay, I see. So is there any swelling around the neck that you might have noticed?
No.
Okay. Does he experience any difficulty in swallowing?
No.
Okay. Does he vomit?
No. None of that I know.
Okay. So you mentioned before that yesterday, right? He has a rapid breathing. Can you elaborate more on that?
Oh yeah. Actually, her mother was the one that noticed his rapid breathing. It is also associated with some kind of wheezing, and his mother also observed that his ribs were some kind of constricted. Can I say that? Constricted, yeah.
Okay, and how was his son during that moment? Is he unconscious or does he feel irritated or agitated at the moment?
No. He was fine. He responded to the mother. Yeah, but he remained silent most of the time. But he was not feeling irritated nor agitated.
Okay, sir, may I know about your son's oral intake?
I can see that he drink less water than usual. and sometimes he even skipped his meals. Like usually we eat 3 times a day, but now he only eats like once every day.
Okay, you mentioned that. It's very important for me to ask this. Have you noticed any symptoms such as sunken eyes or his lips going dry?
No, never.
Okay, do you notice about his urine output? Does it become lower than usual?
I believe his urinations was rather normal.
I see. Okay. So, may I ask, does Ashraf has any history of asthma before?
Yes, he do. He was diagnosed with asthma about 6 months ago, and currently he is on 2 kinds of nebulizer. I mean, inhaler. Sorry, 2 kinds of inhaler, which are fluticasone and also Ventolin, salbutamol.
I see. And is his asthma as well controlled?
Yeah, I believe it is quite under control. I took him to the nearest clinic kesihatan previously, and he had his nebulizer for 3 sessions, and the wheezing disappeared. But then the doctor there referred him to HDAA because the doctor mentioned something about his oxygen level being low.
I see. Okay. Besides asthma, does he have any other known illnesses such as eczema or allergic rhinitis?
Currently, he does not have any other illnesses aside from his asthma.
Okay, I see. Or does other family members have asthma or have the type of disease that I mentioned before?
Yeah. I do, and even my mother as well. We have asthma. Yeah.
Okay. Okay. So right now, sir, I would like to ask you about your son's birth history, if it's okay with you.
Yeah, sure.
Okay. During your wife's pregnancy, I'm very sorry to. Yes, during your wife's pregnancy, does she ever require any blood transfusion or have any episodes of unconsciousness during pregnancy?
The mother have had a low hemoglobin level, but never had any transfusion or any episodes of unconsciousness. Yeah.
I see. Okay. And sorry to ask this, but during her pregnancy, does she smoke?
No.
Very sorry to ask this.
No, she has never smoked in her entire life.
Okay, that's great. Okay, and regarding your son's delivery, how was he delivered?
The labor process was rather normal.
Okay, I see. And do you still remember his birth weight?
Yes, I do. If I'm not mistaken, it was 2.67 kilogram.
I see. Okay. Does he have any complications after the delivery?
Alhamdulillah, he was fine, but only with a few days of jaundice, but it resolved on its own.
I see. Okay, that's great. Okay, now I'm gonna ask you a few questions regarding your son's development. Regarding Ashraf, does he play sports or can he skip at least?
He likes to play all kinds of sports, football, whatever, and he likes skipping as well. He can skip those.
Yeah. Can he hold a pencil or and draw shapes such as triangle or squares?
Yes, he can.
Okay. It's great. Okay. And how was his relationship with his friends?
He has quite a number of friends at the kindergarten, as well as in the neighborhood, and he mingles around very well.
Yeah. Does he require your assistance to dress?
Sorry?
Does he require your assistance to dress?
No. He dressed on his own.
Okay, I see. So right now, sir, I would like to ask regarding Ashraf's feeding history. So may I know that does your wife breastfed Ashraf during his child during previous?
Yes, yes. He was breastfed by my wife totally for 6 months, I believe.
Okay. And then then she continued with mix.
Oh yeah, yeah. And then the breast milk was mixed with formula milk powder up until the age of two years and 4 months.
Oh, okay, I see. And how was his diet?
At 6 months old, he started his complementary diet, starting with solid foods, and now he's on an adult diet lah, I believe. 3 meals every day.
And is he a picky eater?
Not really at the moment. He eats everything that his mother cooks.
Okay, that's great. Does he have any food allergy?
No.
Okay. Now, sir, I would like to ask about Ashraf's immunization history. Does he ever miss any vaccination previously?
No. He got all of them appropriate to his age.
Okay, see. Okay, good. And so now I would like to ask about Ashraf's past medical history. So we talked about before that Ashraf had asthma around 6 months ago, right?
Yeah, it was.
And the medication was fluticasone and salbutamol, right?
Yeah.
Okay, and he does adhere well, right, to medication.
Yeah, he adhered to his inhalers. Yeah.
Okay, that's good. Okay, so from the previous diagnosis, the previous diagnosis from the previous time he was diagnosed with asthma until now, is there any hospitalization or admission to hospital needed?
Yeah, there was. But before he was diagnosed with asthma, he already had multiple episodes where I brought him to the nearest clinic kesihatan for nebulization.
I see. And during the previous diagnosis, during the previous admission, during the previous admission as well, the presentation, Ashraf's presentation is quite the same as before, or is it much more severe during the past?
It is the same. Yeah.
It's the same. So yes, wheezing and so on. Okay. Okay. So in the last month, does Ashraf ever experience any daytime symptoms or nighttime symptoms in which he requires a reliever?
I believe there was none. Everything was fine. Yeah.
I see. Okay. So right now, sir, I would like to ask about Ashraf's family history. Maybe we could detect if there is any pattern in disease. So, sir, may I know about the Ashraf siblings?
Oh yes, sure. He is the second from 3 siblings. The elder one is 8 years old, and the youngest one is 2 years old currently.
2 years old. Okay. And may I know your age, sir?
I am 34 years old.
34 years old. Okay. And this is a very sensitive question, so I'm about to tell you. I'm very so I apologize in advance. Do you smoke, sir?
Yes, sadly I do. I do smoke.
Okay. And do you have any underlying illnesses?
I have a history of asthma. I have allergic rhinitis as well, and I'm also diabetic. But I'm on a diet control currently.
See, what do you work as, sir?
I work as a lorry driver.
Okay, I see. And what about your wife, sir? How old is she?
She is also 34 years old, looking very young.
I see, that's very great. And what does she do?
She is a clerk.
She's a clerk. Okay. Does she have any non-medical illness?
No, she does not.
Okay. So apart from you yourself, you did mention before that there is another family members that has asthma, right? It's your grandmother, right? It's
No,
Ashraf's grandmother, right?
my mother.
Yes. Your mother, Ashraf's grandmother, right?
Yeah.
What about the other family members? Does they have any other non-medical illnesses?
I have asthma.
Yeah. So okay. So now I would like to ask about your social history. So where did you live, sir?
We live in Batu 11.
Batu 11. Is it near the
Airport? Yes, near the airport.
Yes. So it's the area is the housing area is where there is a lot of single-story houses, right?
Yes, and I live in one of them.
Okay. I used to live there too in the previous time. Okay. So it's very important for me to ask this, sir. You mentioned before that you do smoke. May I ask where did you usually smoke? Did you usually smoke in the house or outside the house or away from the children?
I smoke outside of the house, of course, away from my children.
Okay, that's very great. And about your house, is there any dust collecting items such as carpets, flowers, or maybe your son's toys are dusty, which can trigger his asthma?
No, we don't have any of that. My wife is not a big fan of flowers and carpets.
Okay. And what about pets? Do you own any pets in the house?
No, we don't own any pets. But Ashraf here likes to play with the neighbor's cats.
I see. Okay. And in terms of cleanliness, how would you say that your wife clean the house?
Oh, she sweeps the floor regularly. She also washes the bed sheets weekly. And I'm proud to say that our house is free from any cockroaches and house smoke.
Okay. Okay. Thank you very much, Mr. Adib. Thank you very much, Ashraf, for spending your time with me. So I will pass this information to Dr. Mossad, and he will attend you in a moment. Okay. Thank you very much. Sir.
Thank you, Musawa.
Okay, next. Okay, Assalamualaikum warahmatullahi wabarakatuh. So I will be presenting the summary of the history of presenting illness. So my patient, Abdul Arik, 5 years old Malay boy with an underlying bronchial asthma, which is well controlled and on MDI fluticasone with 2-puff PD and MDI salbutamol 2-puff PRN, presented with coryza of clear discharge for 4 days, coughing with whitish green sputum for 2 days, and rapid breathing, wheezing, as well as intercostal and subcostal recession 1 day prior to admission. He denies any fever, sore throat, or chest pain. His oral intake is poor for several days, but there is no lethargy or irritability, and he can still walk. He was brought to Clinic Sihatan for nebulizer after the acute attack. He was nebulized for 3 times, where the wheeze is improved, but his partial pressure of oxygen is remains the same of 88%. And then he was brought to HTAA for further management. And the history suggests that he denies any eczema and other allergies. Okay, next. Okay, from his birth history, his mother had a low hemoglobin anternatally, but there is no blood transfusion.
Musawi, we
Yes.
are not repeating the same knowledge.
Okay.
I asked you for summary. We heard all this before.
Sorry, doctor?
We heard all this before. Can
Okay.
you summarize 2 to 3 sentences?
Okay. So the birth history as nothing significant, I guess. And in the developmental milestone is appropriate with age.
Okay.
And he completed his immunization history.
Okay.
Okay, and next. And family history. He has a strong family history of atopy, where his father and grandmother has asthma. Also, his father has history of allergic rhinitis and also asthma. And on social history, his father is a smoker, but claimed to smoke away from children. They have no dust collecting items, but he does plays with his neighbor's cat often. And there are no other allergen exposure in the house.
Sorry, I would like to ask how, come back to this one, please.
Yeah.
Come back to the previous slide. How come diabetes mellitus on diet control?
Sorry, Doctor.
The second one, the second slide.
Second.
It said he has diabetes mellitus on diet control
Diabetes mellitus on diet control, Doctor.
for the father.
Sorry, Doctor. I'm not very clear right now.
Come back to the next slide. Next slide.
Okay.
Father also.
Yes. Diabetes mellitus.
Diabetes mellitus on diet.
Yes, yes, diabetes mellitus.
To be revised. Only we can use diet for like gestational diabetes, but is it common to treat diabetes mellitus at this age, 33 years, by diet only? Or you just finished your internal medicine? Okay, I think it needs revision. Okay, just put it in your mind, please.
Okay.
You must revise. So what is your working diagnosis?
Yeah. So right now, my working diagnosis is acute attack of asthma, secondary to upper respiratory tract infection.
Very good. So it is EBA secondary to URTI.
Yes.
Very good. So can you tell me what is the course of asthma?
What is that? What is what?
The course of asthma. Usually asthma can be either intermittent or persistent. So what did you suspect your patient has? Has intermittent or persistent?
Persistent asthma, because he mentioned that every December he requires a nebulization in the hospital. Is it clear to my points?
So this is a very important point when we are speaking about asthma. Is it intermittent or persistent? And if it is persistent, we must be able to see it is mild or moderate or severe according to the table in our pediatric protocol. Okay.
Okay.
Okay. So if this patient came to you in the emergency department, how can you state the attack now is mild or moderate or severe or even life-threatening?
We can assess it through the severity of the symptoms, such as for this patient might be mild because he can still walk and he can still talk, and there is no, and he is not agitated or irritated yet, meaning it is not, meaning it is a mild presentation of asthma.
Yes, when these tables are very important to go through the severity. It is very, very important to differentiate now between the course of asthma and the severity of the attack. Okay?
Okay.
Maybe someone has intermittent asthma, but when it came to him, especially if he has hay fever like that, it can come and it is life-threatening.
Okay.
And there will be another patient that has resistance to the asthma. Okay? Or moderate severe asthma, but the attack itself is not, it has different assessment. Okay, good, very good. So let us continue presentation, and at the end I will ask you few points again to give you your marking for your lung case. Okay, be ready.
Doctor, I have a question. For example, like our patient, he is prescribed with fluticasone as a prophylaxis treatment, and therefore, how can we differentiate whether the patient is having intermittent or persistent asthma with that prophylaxis treatment?
Yeah, this is an important point which you are going to discuss, because if the patient has intermittent, no need for prophylactic.
Okay, I see.
Okay.
Okay.
The area here is just try to, you will speak after that about the GINA criteria, okay, how severity, and you are going up and down until the patient became stable. If you are able to stop the preventive medication and use it BRN, like if someone has exercise-induced asthma like that, you can come to another classification.
Okay, all right. So I'll continue with the physical examination. Next slide. So starting with the general examination, Ashraf, the patient, appears to be conscious, alert, and active. There's granula on the right hand dorsum, or the dorsum of the right hand. So the physical examination is done on the second day. Therefore, not all of the chief complaints are persistent until the second day. So there was no sputum pot, no sputum culture and sensitivity, or metered dose inhaler that is seen around patient. Patient is pink, which means he is not cyanotic. Patient is under control, not in respiratory distress. There was no clubbing, no peripheral cyanotic, nor tremor are seen. The patient's capillary refill time is less than 2 seconds, which is normal. There was no conjunctival pallor, no sclerojaundice. Neither nasal polyps nor congestion was observed. Patients also having no rhinorrhea, no enlarged tonsils and lymph node, and the patient's hydration status was good. So the vital signs, patient's blood pressure for as being a 5-year-old boy, it is normal to have 107 over 52 millimeter mercury. His heart rate is 110 beats per minute, which have good volume and good rhythm, normal. Patient's respiratory rate is also normal with a good partial pressure of oxygen at the radial artery. Patient's temperature is also normal. Patient's weight and height, and also head circumference also normal, appropriate to the percentile. So for systems examination, mainly assessing the respiratory exam, respiratory system. So there was no tracheal deviation. Patient's chest moved symmetrically with respiration. There was no chest wall deformities. There was also no scars. There was no intercostal or subcostal recession seen, as what patient's father had told the doctor or Musawa. The chest expansion was good, equal, and also bilateral. Also, bilateral chest was bilateral chest tactile vocal parameters was equal, and the chest was resonance on percussion, and there was a good air entry with equal bilateral sound with no added sound. For patient's abdominal examination, is normal, which is soft and non-tender. There was no hepatosplenomegaly identified. The kidney was normal, non-ballotable. The bowel sound was hit. For the cardiovascular examination, the apex beat was at the normal location, fifth intercostal space. The heart sound was normal, which is S1 and S2 without murmur. For neurological examination, all senses were intact. Okay, thank you.
Okay, Bismillahirrahmanirrahim. Assalamualaikum. So I will be continue about explain what we are thinking about the differential diagnosis. Okay. So in this patient, we are dealing with the respiratory case. So we are interested to point out several differential diagnoses, which is the first in our head is the asthmatic attack, of course, and other four, which is bronchiolitis, laryngeal tracheobronchiolitis, or croup, influenza, and allergic rhinitis. Okay, however, bronchiolitis, we are suspected bronchiolitis due to the this patient have flu-like symptoms. He presented with cough, wheezing, and intercostal and subcostal recession. Okay, and point against, because usually bronchiolitis usually occurs at the patient below 2 years old, usually associated with fever lah. Okay, so whereas this patient is not irritated, have no cyanosis, no hyperresonance, and no hyperinflated chest. Okay, so next one is the croup, the barking cough. Okay, the whooping cough. Okay, so this patient is points for is 5 years old, which is this patient had in the in the age range, so associated with intercostal and subcostal recession, and this patient have poor oral intake. However, this patient does not have fever and no whooping cough, which is this is the most characteristic finding for the group, and no respiratory distress. Okay, so we are suspecting influenza in this patient because this patient has a runny nose, and several days before the admission, he have contact with the patient, with a person who have flu-like symptoms and associated with cough. Okay. However, this patient have no fever, no sore throat, no fatigue, and no myalgia, which is make this patient is less likely to have influenza illness. So the last one, we are suspecting allergic rhinitis, first of all, because this patient have the one of the atopy, which is the asthma lah. Okay, then this patient have the runny nose, have clear mucus discharge, cough, family history of atopy, which is from his father and grandmother. And what is less likely to be allergic rhinitis is the no history of allergen. Okay, then have no eye symptoms, no eczema, and no sinusitis. Okay, so okay, next. So in this case, our provisional diagnosis, we have the acute asthmatic attack secondary to the viral infection. We are dealing with the URTI infection that lead to the acute asthmatic attack, as this patient have the history of the asthma before. So this is the points. Wheezing, this patient have the kidney history of previous asthma, once prescribed with the asthmatic prescription, and the family history of atopy. And the viral infection is due to we are interested in the cough, whitish sputum, and the contact with the flu-like symptom person. Okay, so that's all. Thank you.
Okay, so moving on to discussion, let us discuss a little bit of asthma. Okay, so wait, there's some technical problem here. Okay, so for asthma, it is known as the most common wheezy chronic respiratory disorder in childhood, and until now, it still remains as a life-threatening condition, even though nowadays we have advanced treatment and availability of guidelines. So what is actually asthma? Asthma is actually a condition that is characterized by the presence of recurrent wheeze, cough, breathlessness, and chest tightness with a background of chronic airway inflammation or structural changes that are associated with variable airflow limitation and airway hyperresponsiveness. And it is known to be causes by genetic predisposition, atopy such as allergic rhinitis or eczema, and multiple environmental triggers. So, what are the causes of asthma and what can trigger asthma? So the first one is environmental allergens such as house dust mites, animal allergens from pets, flowers, grass pollens, and then also like we've discussed before, viral respiratory tract infection such as human rhinovirus, okay, and then smoking, cold air, exercise, emotional upsets and anxiety, also chemical irritants such as pain and aerosols. So for how can asthma happen? So it starts with the presence of trigger factor, like I mentioned before, the environmental triggers. It can be multiple or it can be just single trigger factors. So when there is presence of these trigger factors, it will eventually lead to airway inflammation in the trachea. And then when this happens, it will lead to hypersecretion of mucus, airway muscle constriction, and also swelling bronchial membranes. So when these three mechanisms happen, it eventually lead to narrow breathing passage, which produce symptoms such as wheezing, cough, shortness of breath, and tightness in chest. So these are the signs and symptoms of asthma. So generally, like we've learned before, the common the symptoms that patient with asthma can have is wheeze, cough, breathlessness, chest tightness, and also they can have history of atopy such as eczema or allergic rhinitis. And then for sign on inspection, they can have altered consciousness, respiratory distress, cyanosis, dry skin, or even eczema, decreased pulsatile weight and height, hyperinflated chest, and also Harrison sulcus. And then on palpation, there will be CO2 retention, decreased chest movement, decreased vocal frequency, increased anterior posterior diameter, which means hyperinflated chest. And next one for on percussion, there will be hyperresonance to percussion. And then on auscultation, there will be diminished air entry. So it will be vesicular breathing with prolonged expiratory phase, generalized expiratory rhonchi, and also there will be presence of crepitation in infants, especially. And then moving on to complication of asthma. So the first complication that the patients can have is status asthmaticus, which means severe acute asthma, or it can be known as severe asthma exacerbations that is not resolved with traditional medication, and it can last for minutes to hours, and it is also known as life-threatening condition. And then pneumonia also can happen, which it is because it is due to previous lung damage and weakness of the lung tissue due to severe asthma that will then lead to respiratory failure. And then atelectasis, which means collapsing of the lung. Then the next one, moving on to investigation and management that represented by Atika.
Okay, Bismillahirrahmanirrahim. So I am Atika. Can you hear me? Okay. Okay. I will proceed with investigation and management of asthma. So I will start with investigation. Okay. So the first investigation is so basically to diagnose an asthma is based on the good history taking and physical examination. However, we need some special tests to be conducted to exclude some other pathology or underlying disease. So the first one is pulmonary function test, where the main test is the spirometry. So this spirometry measures the flow and volume of air blown out after a child takes a very deep breath and then forcefully exhales. So this spirometry basically measures two key factors, which are the forced expiratory volume in 1 second and forced vital capacity. So in obstructive features, which one of the diagnosis is asthma, so they will have the normal or reduced forced vital capacity, reduced forced expiratory volume in 1 second, and for the ratio of FEV1 or divided by FVC would have the less than 70%. So this is opposed with the restrictive disease, where the ratio would be more than 70%. So this test is then repeated using inhaler or nebulizer if there is any obstructive features. So to confirm asthma, as we know that asthma is the reversible bronchial constriction. So if this is repeated using inhaler or nebulizer, so the value for FEV1 will increase about 12%. Next slide. Next slide. Okay. So next is the peak expiratory flow rate. So basically, PEFR is not mainly for diagnosis. It is more towards the monitoring the patient. So what is PEFR? So it is actually a maximum flow rate generated during a forceful exhalation, starting from full lung inflation. So this is given in liters of air breathed out per minute. So in obstructive disease such as asthma, as I mentioned, the PFR value would be less than 80% of normal predictive value. So actually for PEFR, it is depend on the age and the gender of the patient. So you guys can refer the list and this is the list of the normal predictive value for PFR for Malaysian children later. As I mentioned, this PFR is for monitoring and is useful in home to predict any asthma exacerbation and very useful in asthma management plan. So this PFR is measured by peak flow meter. So next slide. Next slide. Okay, this one. So the other test for the pulmonary function test is the challenge test, where it is designed to cause the airway to narrow in children with asthma. So the most common challenge tests include the inhaling an agent such as methacholine, and this is the most common agent, or exercise by running on a treadmill or using an exercise cycle or breathing cold air. So in asthma patient, they will show hyperresponsiveness, such as the features would be heart rate will be greater than 60%. So this in this test also, the spirometry is performed before and after the test. So the other test is the fractional concentration of exhaled nitric oxide measurement, and this test measurement is associated with increases in eosinophilic levels. So an increase in FeNO will for more than 4 weeks after upper respiratory infection in preschool children, such as in this case, with recurrent system may help in the diagnosis and in predicting intranasal corticosteroid use by school age. Next slide. Okay, so next the other investigation, which is not commonly. Yes, doctor.
We need to hold for a few minutes. You are extubating one baby, and then I will continue with you. Okay.
Okay.
You can even discuss this one together until the end.
Sorry, doctor.
You can present this slide together and stop after.
Okay. Should I continue or wait? Anyone?
Continue this slide only. This slide only.
Okay. Next slide. So this is the additional info for diagnosis of asthma in children for more than 5 years old. Okay, we can read later. Next slide. Okay, so I'll proceed with the management. So the goal of management in this asthma patient. Oh, okay. So no need to present, right? Okay.
Yang tadi radiografi tu Atika skip ke?
Radiography tu sebab doktor kata kenapa?
Doktor suruh present yang ni je.
Alright. Okay, so for the radiography, it is not commonly done, but if the initial work, it is will very useful if there is any suspected for the complication of asthma, such as the pneumothorax or pneumomediastinum. Okay, the other tests will be very helpful also, such as the allergy test. Yeah, that's all. Okay, next slide. So for management, I do not need to present, right? Yes, present next. Okay.
Tunggu doktor.
Okay.
Atika boleh ke nak tanya?
Tanyalah.
Untuk test kan, biasa kalau yang biasa kita buat dekat hospital setting, memang kita buat yang biasa buat lah. Memang kita buat 4-4 ke ataupun kita buat spirometry dengan PEFR tu?
PEFR tu selalu buat juga lah, tapi dia tak untuk diagnosis lah, tapi dia more tu kepada monitoring. Selalunya untuk first diagnosis dia akan buat spirometry. Tapi lepas kan ada asma kan dia akan ada follow up kan. So dia akan sekali guna lah untuk PFR, lepas tu challenge test tu buat juga lah untuk supportive diagnosis macam tu.
Yang main untuk diagnosis cuma spirometry je lah.
Main dia sebab yang kurik yang tu lah.
Okay. Lepas tu dapat result dia yang less than 70%.
Less than
itu
70%.
dapat diagnose asma.
Tapi kena tengok jugalah buat chest X-ray ke apa untuk tengok macam ada pneumonia ke apa ke yang selain daripada asma.
Okay,
tapi selalunya
dengan simptom history juga lah kan.
Okay. Tapi selalunya buat je untuk tu PAFR tu semua.
Selalunya buat juga.
Dia tak adalah macam depend on spirometry only. Dia macam buat untuk supportive tu buat je PFR tu. Tapi PFR tu kan tergantung kepada result tu, kita pilih kepada spirometry lah.
Thank you.
Alright.
Okay. How much is the flow? Huh? Sorry? Yeah, sometimes.
I don't have to set the flow.
This one cannot like the other one.
You only have to do it if it's oxygen therapy. If it's
But this one can be buyback? This machine can be buyback? Okay, if you are doing it buyback, it will be better. Make like the people is before it was 18. So like the VIB 18. No, I should make it 18. 18, 1 8. The VIB make it 18. And the B make it 6 now or 6.5 only. Okay, oxygen 50. 18. Okay. Correct. Okay. Did you finish already? Hello?
Okay. Wait, not yet. Should I proceed now?
Okay.
So, okay. I'll proceed. So this is just the additional info to diagnose for asthma in children for less than 5 years old. So basically for asthma, it is very difficult to depend on the investigation that I mentioned before, such as the spirometry, because because episodic wheeze and cough is very common in this age group, especially in 0 to 2 years old. So next slide. Okay, so I'll proceed with management. So for the management, the goal of therapy is to maintain of normal activity, including the ability to exercise, no absence from school, no visits to the emergency department due to asthma exacerbation, no mortality, and no side effect from the medication. As we know that asthma is the long-term disease, and okay, so the comprehensive management will be include the educations, where the doctor should explain about the disease nature and its treatment, written asthma action plan, and education on exercise, as we know that as exercise also could trigger the asthma, but at the same time children need to do exercise for their developmental milestone. So the other will be the avoidance of trigger. So this is more like the preventive measures that should be taken, such as the smoking, air pollutants, allergens, respiratory tract infection, also obesity. As we know that the person with obesity has more chances to get worse asthma presentation. So the other management will be strategies to optimize pharmacotherapy plan. Next slide. Okay, so this is the asthma action plan that should, I mentioned before, that should be written by the doctor, and that should be used to guide the parents or caregivers about what should they do when the children might have asthma exacerbation attack. So next slide.
Simple section, please. Yeah.
Okay, so for the drug therapy, we have the reliever therapy and preventative therapy. So for the reliever therapy, it is given to alleviate any respiratory symptoms associated with an acute asthma event. And the drug of choice will be the short-acting beta agonist, such as in this patient, we know that the children is given the salbutamol. So, and this is prescribed only when the necessary and not used in a long term, like must be used in everyday or any and then we have the preventive therapy. It is given as the anti-inflammatory treatment to prevent the symptoms. So this preventive therapy depend on the age of the children, asthma with phenotype, which is we have the episodic viral wheeze or the multi-triggered wheeze, and the frequency of severity of symptoms. So for the inhaled corticosteroids is a drug of choice for multi-trigger wheeze. And then when asthma is not well controlled with standard dose of the inhaled corticosteroid, rather than you increase the dose of the corticosteroid, the long-acting beta agonist should be added. Because if you increase the dose of the ICS, it will be increase the worsen the side effects of the medications. And if asthma is well controlled for at least 3 months, the doctor should consider the reduction therapy. So for the leukotriene receptor agonist, it is used for a long-term preventer and especially for the episodic viral wheezing. So for the drug therapy, the preferred would be inhaled. Yeah, yes, doctor.
Tika,
Yes.
for you, as year 3, we are not suspecting you to go deep for the treatment, just to know the line. It is very
Okay.
important to know that we have 2 types, which is the reliever and the preventive. Okay,
Alright.
because our goal with any chronic disease is not to let him come time after time how to prevent this one. So to know the preventive medicine as steroid, inhaler, as leukotriene is enough as a general line. So your colleague can swallow the dose of knowledge about an important disease. Okay. Do you have any other slide, or this is the last one?
other slides for the okay. So this is the algorithm for long-term management plan, and for the persistent asthma, you can refer in the clinical guidelines after this. Next slide.
Okay.
Okay, so this is management generally for acute asthma exacerbation, and the drug would be the short-acting beta agonist, parenteral or subcutaneous in severe acute asthma. And if the patient have as the partial pressure of oxygen left with less than 95%, the patient will have the doctor should have deliver the oxygen with short-acting beta agonist. Another that you can do is systemic corticosteroid in acute exacerbation. And other drug will be ipratropium bromide, aminophylline, or intravenous magnesium sulfate. So this is depend on the severity of the asthma exacerbation. Okay, next slide. Okay, so this is just the table of assessment of severity. Okay, so this is very important for management plan. Okay, I think that's all. Next slide. Okay, so this is just a follow-up that should be assessed by the doctor around a degree of asthma control, compliance to asthma therapy, and also asthma education. Okay, I think that's all. Thank you.
You just need to add one more line with the last slide, please. So degree of asthma control, compliance, because sometimes there is uncompliance due to children resistance or the family neglect, asthma education, and the last one, social issue. Any chronic disease, we must be able to sort all the social issue. How far he is from KK, emergency, what he is going to do. What about his life? He is living a normal life, like he can go to the school, like that. He can attend family gathering or not. He can do some exercise, because the social impact are very important, and we must put it in our assessment, okay, of severity and recurrence. So don't forget, for any patient with chronic problem, to consider the social situation. We are not only a doctor who will get paper and pen and write some medicine. No. If you are not managing the child as a whole, like this asthma, which has increasing in trend nowadays, it's very increasing now, okay? So we must take care about that. Good, you are making a good preparation, even exceeding the expectation for you as a starter for year 3. I'm a bit happy with you. Just revise any diagnosis, it need us to go through 3 steps. Yes, the first step is the history. You must know the history step by step as your friend present, and for every patient. And this one will give you knowledge about 70% or more of the truth. Then 25%, it's your clinical sense to pick how I know that is it asthma or not, how can I know its severity, okay? And then the next step, the investigation which I need. As you know, most of the time for asthma, we are not going to do a lot of investigation unless we suspect a complication, like it is accompanied by pneumonia, like the patient are very, very critical, so we are suspect complication, okay? Otherwise, we have something known as bedside test. What is bedside test? It is some investigation which we can do on the bed, and we can define the severity. Of course, if you ask the patient, what's your name, and he cannot say his name, did you, I offer him food, he cannot get the food, all these are indication of severity of the asthma, okay? But there is 3 investigation all on your hand. The first one is the pulse oximeter. The second one is the arterial blood gas, to make sure the patient has respiratory failure or not, and if it is it type 1 or type 2? Because it will start type 1, and if deteriorated, it will go also for type 2. The third one is both of them together to make the BAFR, especially from 5 years and above. So all these are considered bedside tests. So it is very easy. By history, the patient has severe recession, has desaturation, he cannot eat, he cannot play, he cannot even speak his name. All this, it will guide you that the case is not simple, it's severe, it's complicated. Okay? At the same time, just a simple bedside test, it will guide you to manage the patient as a whole, as a part of the family, and prevent is our goal. Okay? Good achievement for the first case. So our presenter now, I will ask him simple question. Where is the doctor?
With Oski.
No, the first one who presents.
Oh, Musawa.
He left.
Yes, that I'm here.
Why you are escaping?
No.
Musa.
Yes.
What did you suspect can be the cause of exacerbation of asthma?
In this patient, Doctor?
Exacerbation causes.
In this patient, Doctor?
In any patient? No, I'm speaking generally now. I'm asking you. I have asthma. What is the causes that can exacerbate my asthma?
Okay. First of all, can be any pollens, or can be any dust, or the first from pets. If we have any cats or dogs, can exacerbate our asthma. And sometimes when exercise can also exacerbate asthma. And cold air maybe sometimes can also exacerbate asthma.
Okay. Also, cold
Allergens.
Cold exposure. Cold exposure to cold, like cold atmosphere, cold water, sometimes it can exacerbate.
Yes.
Another thing is the
cigarette smokes.
Psychological.
Oh,
I mean,
psychological.
Yes. If the patient of asthma became very happy and he sit inside the TV and laughing, what do you know will happen? He started to cough, and then started to go to him. Even if he became very depressed and crying, he will start to go. So we need for any patient of chronic condition to be middle of his emotional situation. Okay, this is a very important point. So all this, you must go through the history to ask about all these points.
Okay.
You must define how many causes. The second question, now you examined the patient and found him has mild persistent asthma, which is, or moderate persistent asthma, which is improving and like that. So what is the next system you need to examine other than the chest in case of asthma?
Other system to examine.
Yes. We speak about the respiratory system by clinical examination, even by bedside test to see if there is respiratory failure or not. But is there any other system you need to examine?
Maybe
yeah. I will make it more easy. Atika Ghani.
Yes, Doctor.
Yes. What is API? API.
API, Asthma Predictive Index.
Yes. Yeah, by Arabic it is Abi. Abi means my father, but by
Oh,
By
okay.
ABI, it is
Okay.
Asthma Protective Index. What is
Yeah.
ABI?
AP.
Yes.
So basically, or if I'm not mistaken, asthma predictive index is an assessment that should predict asthma. That should predict asthma whether it's triggered. If not, so wait a minute. Okay. I
So
think
who
I've
can
searched.
answer? The one who prepare. I need you to be ready.
Yeah.
So any score now, you must be able to set what is the statement and what is the parameters. You must know the statement is that the patient got 3 attacks of wheezy chest plus either one major or 2 minor. Okay, you will find in both major, number 1 is the dermatitis or eczema. So please, if you found any patient with asthma,
Major dengan minor. Yeah.
yes, if you find any patient with asthma, you must come back to Musa and tell him you must go through the skin. If the patient has eczema, because it's different. If the patient has eczema beside asthma or rhinitis beside asthma, we need to choose our preventive medication. So the next system will be skin.
Skin.
At the time, if he has also eczema, I am going to do prick test for the skin to define what is the irritating thing is for him. Okay, good. So you started now with the most common and evolving with industrial countries now is the asthma. And all the details you are speak about is in the benefit of the patients. And one thing I need to inform you more is the importance of breastfeeding in case there is family history of asthma. Do you know that if the child got, or the baby got 6 months exclusive breastfeeding, the asthma prevalence dropped to 50%. And its severity also drops by like that. So number 1, we need to advise the mother. If you are going to conceive again, please remember to give your child only EBM for breastfeed for the first 6 months. Don't give him anything else. Okay. The one thing more, which is take care of about bits, about toys, about mites. Mice, small insect, if we are not able to follow it, the patient with asthma can smell it and be reactive to it. Also, cats, mites, all this one can affect the patient with asthma. Okay, so try to take care about of all that so your patient will not stay with you in the hospital forever. He can go for life, he can be productive. If he's a student, he can be a good student like that. Okay, thank you. I think today it is enough for you, this a big diet case. And inshallah, hope we see you again to present the second case, inshallah, with the next meeting with us. Okay. Anyone has any question?
Doctor.
Any question?
Actually, the second case.
I think it is difficult. Time now is running, and we have a lot of cases here. Okay, maybe with the next inshallah meeting, we can compensate for it. Okay.
Okay. So we should reschedule the time.
Let us see the next schedule with me. You don't have any meeting with me again?
I think this week no more.
Okay.
Unless you are okay to do class at night or weekend.
Okay. Okay. If you don't have any meeting with me, I prefer to present for me one more case. It is for your benefit. It may be, yeah. Be ready. during the weekend, I will contact you, inshallah. Maybe Saturday or like that. Okay.
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 Thank you. Just record your Musa, your score now 7.5. Okay.
Sorry, Doctor. 7.5.
Okay.
Okay.
Assalamu alaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Doctor.
You are
Thank you very much, Doctor.
welcome.
Thank you, Dr.
Assalamu alaikum.
Waalaikumsalam.